Welcome to On Health with Houston Methodist. I'm Zach Moore. I'm a photographer and editor here, and I'm also a longtime podcaster.
I'm Katie McCallum, former researcher turned health writer, mostly writing for our blogs.
I'm Todd Ackerman. I'm an editor here, and I'm a former medical reporter.
I'm Kim Rivera Houston-Weber, and I'm a copywriter here at Houston Methodist.
And Todd, we're talking about inflammation today.
That's right.
Do you have it?
That's the $64,000 question, Zach.
That's an old TV show, by the way.
Okay, I was about to ask, how did you pick 64,000? So what's the reference I'm missing here?
It's a, I think the derivation is a TV show, but it's a very common phrase.
Yes.
All right, you learn
For
something every
something
day.
that is hard to know what the answer is.
It's the equivalent of saying, is that your final answer, just for
Is
an
it
older
because
generation?
64 is like that magic number thing? Is that what this is coming from?
That was a lot of money in the 70s, right?
Yeah, I think it was before the 70s.
Oh, okay, well, I was giving you some credit. Anyway, it's a very important question. We went into it today. Now, chronic inflammation, right, is more what we're talking about today?
Yes, I think everyone's familiar with acute inflammation when you have an infection or you suffer trauma to a part of your body and you can see it swell up and become red. Mm-hmm. But we're talking about low-grade chronic inflammation, which is really a sort of silent thing like high blood pressure or cholesterol, only there's no test for it, or there's no commonly ordered up test. There's also not a lot of medication out there for it, but it's increasingly seen as the culprit behind a lot of our deadliest diseases.
Does anyone have chronic inflammation here? Not to put you on the spot.
I mean, it kind of sounds like you almost can't know till it's too late.
Yeah.
I don't know. You tell me, Todd.
There is one test that has to do with the heart, but I don't think it's very commonly known. So yeah, I think generally you're not really going to know. The best thing is to be proactive about it, which we'll talk about. But the odds are that somebody here might, because there was a...
It's probably me.
One of us has it.
There was a
Who
recent,
is it?
There was a recent study that 60% of people have some sort of inflammatory condition and 40% have two.
Okay, well, so it sounds like one of us maybe has two, and at least two of us have one.
Yeah.
So
Look to your left, look to your right.
Yikes.
One of those people. has
You guys will
inflammation.
probably have a better chance than me because I think it's probably something that increases as you get older.
So
Yeah.
age is a factor. You think?
Yeah.
Okay.
And I think, I mean, I was probably a little doom and gloom with how I answered, but like what we're going to get into today is how maybe the tests aren't quite caught up to detecting it, but there are obvious sort of lifestyle factors, I think you would say, that sort of, if you're doing a certain number of things that we're going to talk about today, your chances of maybe having chronic inflammation are a little bit higher, right, Todd?
Yeah.
So we'll all be really excited to hear about those because I'm sure it's all the things we love to do.
Yeah.
It's something that you really can't know if you have it, but it seems like there's a lot that you can do to potentially prevent it. Because if you're eating well, if you're exercising, if you're doing the things that you probably should do to just take care of yourself, it can kind of help lower that risk. And, it's crazy how so much of these sort of lifestyle actions that you can do are preventative for all sorts of disease states.
No, that's a good point. And that's something we've learned throughout the podcast here on Health is how interconnected all these things are, right? We compartmentalize like heart health or food or exercise, all these things, and they all work together to improve your quality of life. Now, they're not necessarily going to keep you from getting ailments. Like you can be as healthy, you can do all the right things and still suffer certain ailments, but really can't hurt if you're doing all the right things, so to speak. Right, Todd?
Well, in the case of inflammation, it not only couldn't hurt, it's sort of the prescribed thing to do to prevent it.
Yeah, and Zach, I think it's kind of perfect that you brought up the interconnectedness of everything. We've talked about it several times on this podcast, and I don't think there's probably a better example of how interconnected everything is than chronic inflammation. I don't know. Do you agree, Todd?
Oh, yeah.
Yeah. I mean, and it's so many of these things we talk about, like Kim said, diet, lifestyle, be healthy. But I think this is actually probably the best example of how basic and why it matters, because it's going to kind of be the foundation of things.
Right.
Well, who did we talk to today about this, Todd?
We talked to Dr. Joshua Septimus, who's a associate professor of clinical medicine at Houston Methodist and something of an authority on this subject. So we're here with Dr. Joshua Septimus, associate professor of clinical medicine at Houston Methodist. Greetings, Dr. Septimus.
Greetings. How are you, Todd?
I'm good. Good to have you here for this conversation on inflammation.
Thanks for having me back.
Just reading up a little bit on this today, I saw the World Health Organization rank chronic inflammatory disease as the greatest threat to human health. Do you agree with that?
Ooh, that's a bold statement. I have not read that yet.
Is that really the culprit behind our deadliest diseases?
I think it's part of the equation. I think it would be hard to say that one particular trigger is the single unifying theory. I know people are always looking for that single underlying reason for everything under the sun, but I certainly think that if you look at the biggest killers, particularly in the Western world, you're talking about heart disease, strokes, cancer, Alzheimer's disease. All of those things have chronic inflammation as at least a participant in the disease process.
I think everyone's familiar with acute inflammation, the redness and swelling that result after a wound or infection or injury. Not so much chronic inflammation. That's a cause of disease. Can you give us a quick explanation and example of that?
So we have, since at least the 90s, when I was in medical school, started to think about chronic low-grade inflammation as a cause for chronic disease. The biggest example being heart disease, where there was a contrarian at the time theory that people who had underlying atherosclerotic heart disease had an inflammatory component to that plaque, that cholesterol plaque that would rupture and cause heart attacks. And there was actually some pioneering work done here in Houston on that. So when I was in training, that theory was becoming more and more prevalent. There was an investigator named Paul Ridker at Harvard who started measuring a special type of inflammatory marker called a high-sensitivity C-reactive protein and correlating it with active cardiovascular disease using a new risk equation that he and his team developed. And so from that cascade of events has come this theory that inflammation is playing more of a role than we think. And there have been a number of clinical trials now evaluating that, using pharmaceuticals to even help modify that risk. There was a big trial using rosuvastatin, which is a very commonly used statin drug now, name brand Crestor, where they took patients with heart disease who had good, well-controlled cholesterol and put those patients on rosuvastatin if they had an elevated high-sensitivity C-reactive protein and showed a huge reduction in cardiovascular disease. So proof of concept. And since then, there have been some investigative drugs that they've attempted to study in reducing cardiovascular events. And just recently, there was drug approval for the use of an old drug previously used for gout called colchicine to reduce the risk of recurrent cardiovascular disease events. So now if you're on statin therapy and all the other standard of care modalities for treating your heart disease, now cardiologists are starting to put you on an anti-inflammatory to reduce the risk of heart attack and stroke. And that's one of these game-changing chronic inflammation pharmaceutical modification of your risk that we're seeing with this low-grade inflammation that you can only find with this special test, the high-sensitivity C-reactive protein. And there are examples all over the place of chronic inflammation leading to disease that spans from really poor data to excellent data, like the cardiovascular disease. So it infiltrates many aspects of medicine.
And this started in the 90s. By medicine standards, that constitutes kind of a new field, right?
Yes. And by the way, I don't know if that's the first time anyone thought about inflammation, but I know in terms of cardiovascular disease, at the time, it was considered to be a relatively revolutionary idea.
But
it's still sort of early in the field, that they're still learning about it. It's still something of a mystery.
Absolutely. And if you think about it, we have one FDA approved medication to treat that inflammation. And that tells you, whenever there's something that's as common as cardiovascular disease that only has one medicine, it's in its infancy. And I would be shocked if there were not a dozen other medicines in development that are going to follow the colchicine story.
So why did it take so long, though? I mean, it seems like inflammation is well known to doctors in so much of disease.
Well, I think you're looking at it from the lens of 2023. If you look back to the 90s, when I first got into medicine, inflammation was really associated with autoimmune disease when you're talking about chronic inflammation. Things like rheumatoid arthritis, things like systemic lupus erythematosus, things like Sjogren's disease, all of those chronic autoimmune diseases. And it's been in my career, in my medical lifetime, that we now tightly associate all of these chronic inflammatory conditions with cardiovascular disease. Why, again, this inflammation? I think it's that we've been focused on what our technology could evaluate. So in the 80s, I believe, is when they came up with, for example, cardiac stents and what are called PCIs, where you just opened it up with a balloon. And at the time, I think it was more of a plumbing hypothesis. Oh, they just got slow accumulation of plaque. There wasn't as much of an elucidation of this being more complex than that, because these were the tools that we had. We didn't have statin therapy. We didn't have so many of these other non-mechanical therapeutics. And similarly with cancer, think of how much more we know about cancer now than we did in the 1980s, and how much has been published in that time on the relationship between metabolic syndrome, which is central obesity and insulin resistance, which, by the way, is another chronic inflammatory condition, and the risk of cancer. Why? In my opinion, because it's a chronic inflammatory condition, and that high insulin level and metabolic syndrome, it's all tied in with this inflammation. But all of these things are relatively new in terms of what's being researched and what people's thought processes are.
So I guess I'm thinking of all the itises, sinusitis, colitis, tendinitis. I mean, I was told I had chronic sinusitis back in the 80s. Is that what we're talking about, or is that a different animal?
No, so even chronic sinusitis would be considered more of an acute phase response, even if you have chronic sinusitis that goes on for months. And it's a much more, you can measure that C-reactive protein that I was mentioning earlier. You can see in someone who has sinusitis that that's elevated even without that more sophisticated high sensitivity assay that I was talking about. We are talking about very low levels of inflammation and even localized levels of inflammation that are in only particular areas. So it takes a much more nuanced approach to inflammation than the diverticulitises of the world and the gastroenteritis and the sinusitis and those types of things that are clinically in front of your face. You can see someone that has an acute infection or abdominal pain or acute, gastrointestinal infection. You can't see those chronic low-grade inflammations that lead to vague symptoms or no symptoms at all.
And there's not an obvious trigger.
I think in a lot of cases there is. I think a lot of times we don't want to see those triggers. I personally think that processed foods and just our American lifestyle in general are enormous triggers for chronic inflammation. You're never going to be able to prove that in a randomized controlled trial, but clearly people who eat a lot of processed food, a lot of processed sugar, have high levels of inflammation and therefore high risk for all of these other diseases that we've talked about already. But again, these are all subtle, very, very low grade, as opposed to the person who has an attack of diverticulitis and has to go to the hospital because they're in abdominal pain.
So the thing is that people usually don't know about this until it's progressed to the point that it's caused disease. It's insidious.
Correct. Insidious is a great way of describing these chronic inflammation conditions. And in fact, I think that most people don't even associate chronic inflammation with the diseases that are self-evident. I don't think if you were to ask the average heart disease patient, do you have an inflammatory condition? I think the vast majority of them would say no. Whereas I would say, absolutely, if you have heart disease, that's an inflammatory condition.
Is there any way to know if you have inflammation, if you don't have obvious symptoms? Or are there more subtle symptoms to be on the lookout for?
Well, I think you have to start by looking at it on a disease by disease basis. There are some diseases, for example, cardiovascular disease that I keep going back to, where we have that high sensitivity C-reactive protein. And if you have a high sensitivity C-reactive protein of less than 1, your risk is very, very low. It doesn't exclude that you could have a really low grade inflammation, but it helps. I don't know of lab tests for chronic low grade inflammation in any other disease state. Doesn't mean they don't exist, but I don't know of them. I think that when you say what are the symptoms of chronic inflammation, you get a little bit off the rails of what I would call traditional allopathic medicine. So allopathic physicians are doctors like me who practice kind of traditional medicine. Osteopathic medicine is very tightly related to allopathic medicine. And so I think when you talk about allopathic and osteopathic physicians, we would say that there's no hard science behind symptoms of chronic inflammation. But going slightly off of what we know with hardcore science, I think people who are struggling with chronic fatigue, people who are struggling with sleep, people who are struggling with chronic pain, one as a physician should at least think about inflammation in those cases and what you can do to reduce their inflammation, even if you can't measure it. I'll give you an example. You have a patient who is struggling with fatigue and generalized aches and pains, and you see them and they're not living a very healthy lifestyle. Well, I would go back to that person and talk to them about what we can do, not necessarily explicitly saying these are things to reduce your inflammation, but that is what I'm thinking in the back of my mind, and say, okay, let's talk about your sleep. Because if you don't sleep well, your stress hormone levels are going to be high. Let's talk about your stress. Do you need to practice mindfulness? Because if you practice mindfulness and you reduce stress, you're going to reduce inflammation. Let's talk about your diet. Let's get the processed foods out of your diet. Let's get you exercising, because if you're exercising, you're going to reduce inflammation. If you can get patients to buy into that, you're going to have a high success rate in getting them to feel better. You may not get them to feel perfect, but I think you can get them feeling better.
Is there a genetic component to this at all, or is it mostly kind of in your mind probably a diet lifestyle thing?
There's no, that I know of, hardcore scientific data, but I think look at families. There are some families where everyone in the family struggles with obesity. Everyone in the family struggles with their gut. And there's other families where family members don't necessarily take great care of themselves, and yet they have longevity. They are not severely overweight. They have good energy levels. So I do think there's a genetic component to it. And there are some people who are really lucky who, man, if you've got that genetic lottery and you also take really good care of yourself, those are those people who are in their 90s who are still working and productive and feel good, because you got to have both. You got to hit the genetic lottery and you have to take care of yourself to make it that far.
Do you talk about this with your patients a lot? Is it hard to get their attention about something that's kind of silent and amorphous?
So those are two very different questions. Yes, I do talk about this with my primary care patients. The problem is, as you can tell from this discussion, it's incredibly nuanced and it's incredibly time consuming. And it involves asking people to make enormous changes to their lifestyle. There's a physician named Peter Attia who he's become a little bit of a cult hero to the longevity community. Fascinating guy. He lives in Austin, who calls our American diet the SAD diet, the standard American diet. And that's what the vast majority of my patients follow. It's a diet heavy in processed foods. It's a diet that is very high in calorically heavy and nutrient poor foods. And what we should be eating is a diet that is real food, that is nutrient dense and calorie poor. But that's not what's easily available. It's not what's cheap. It's not what stays good in your refrigerator or on your counter for long periods of time. So it's hard. And when I ask patients who for their entire lives have been following that SAD diet to make changes, it's incredibly difficult to break through. It doesn't mean I don't try, and it doesn't mean that anyone listening to this podcast shouldn't try, because even small changes can make enormous differences, but it's hard.
Dr. Septimus mentioned the type of foods that lead to inflammation, the so-called standard American diet, processed foods, and foods high in calories and low in nutrients. Here are the leading specific ones to avoid: red meat, bacon, hot dogs, lunch meats, and cured meats, refined grains, including white bread, white rice, pasta, and breakfast cereals, snack foods, such as chips, cookies, crackers, and pastries, sodas, and other sweetened drinks, and fried foods. What should you eat instead? You may have heard it touted before, but the Mediterranean diet is considered a model anti-inflammatory diet. It's heavy on plants, whole grains, and fresh, unprocessed foods. And the prioritized protein options contain less saturated fat and more omega-3 fats, such as salmon, mackerel, sardines, and certain tunas.
These conditions tend to be degenerative conditions?
Not necessarily. I wouldn't call heart disease degenerative. I wouldn't call cancer degenerative. But chronic inflammation can lead to degenerative conditions. I don't have a randomized clinical trial where I can tell you that Alzheimer's disease is clearly a inflammatory linked condition, but I do believe that. And so that would be considered degenerative from chronic inflammation. And obviously, if someone has rheumatoid arthritis, they slowly, if they don't treat their rheumatoid arthritis, will develop joint degeneration. But I wouldn't call chronic inflammation a degenerative condition all in one, because I think it's more subtle than that.
Okay. You mentioned autoimmune diseases. Are those considered an example of this?
Autoimmune diseases are absolutely chronic inflammatory conditions.
But the biggest mystery of all, right? How they develop and what's going on, why the immune system is going so haywire?
What I would say is we know a lot about autoimmune conditions. We know that there's a genetic component, and we know that there's something environmental that probably contributes to trigger the immune system to go haywire, but we usually can't identify that one particular thing.
So what do we know about the process by which inflammation causes disease? What happens as it continues over time?
Well, I would take you back to heart disease, where we know the most. When you get atherosclerotic plaque, what's happening is you are getting cholesterol deposited underneath your endothelium. Your endothelial layer of your heart is the lining of your blood vessel walls, and cholesterol gets deposited there. And once it gets deposited, it triggers an inflammatory response. And that inflammatory response grows the clot, damages the blood vessel wall, and makes that blood vessel wall more prone to further damage, and eventually leads to plaque rupture, which is what causes a heart attack. I don't have a good feel for what the underlying pathology is of chronic inflammation leading to cancer, for example. I'm sure somebody else knows that answer, but
Is obesity always predispose you to inflammation?
I believe it does, yes.
But you can also have inflammation going on if you aren't overweight?
Absolutely. And there's an interesting concept in endocrinology and in bariatrics now of the healthy obese, meaning people who are technically body mass index over 30, but they are metabolically healthy. And those patients are not going to have a whole lot of inflammation. And then people who are the non-obese, but metabolically obese. And those are the metabolic syndrome patients. Those patients, even if they're not struggling with obesity, they're metabolically obesity, meaning they have insulin resistance, they have a low HDL, they have a high triglyceride. If you did fasting insulin on them, it would be high. Those are the patients that you see who are much less healthy than they appear. Much more common in people from the Indian subcontinent. We see a huge risk of diabetes in those patients, even though their body mass index would not indicate obesity. And in fact, the guidelines for metabolic syndrome are different depending on your race as a result of that. So people from the Indian subcontinent do not need a waist circumference of 40 inches the way that Caucasians do to get that tick, that checkbox for metabolic syndrome.
In your mind, are weight issues the primary risk factor for inflammatory disease?
I wouldn't call it the primary. I would call it a significant, because I think it's just much more complex than that. And I think obesity is very prevalent in the United States, for example, but there are other places where it's not as prevalent, where you still see a lot of chronic inflammation. So I think certainly it's a contributing factor, but I don't know that I would pick any one thing and label it as the primary.
But what other risk factors are there?
There's, as we talked about, there's genetics, there's diet, there's stress, there's sleep disorders, any number of environmental factors, toxins that, like if you live in a city, for example, where the air is heavily polluted, that's going to promote inflammation. There's any number of things that you could point to.
And so what can you do to prevent it?
My take home is really, it's one of those things where it sounds so simple, but it's incredibly hard to implement. When I start talking about this with patients, I tell patients the easiest way to think about inflammation is actually to think about insulin. So we always think about insulin as being this life-saving hormone that diabetics need to survive. But in fact, most diabetics are type 2 diabetics, and type 2 diabetics are resistant to insulin. So when patients become insulin resistant, which that's the majority of the inflammation that I see is people who have chronic insulin resistance, everything you can do to reduce your insulin level is going to be good for inflammation. The reason I like this way to discuss it is it's simple. What am I doing with my body and what am I putting in my body that will reduce my insulin levels? So if I am eating processed food, I'm increasing my insulin levels substantially, as opposed to even if it's the same number of grams of carbohydrate if I'm eating vegetables. The difference between my insulin response to those two carbohydrate loads is going to be markedly different. Everything you do with your body. So if you are sedentary, your insulin response is going to be terrible. But if you are physically fit, you are going to have a much more healthy insulin response. And even one up from that, if you build healthy muscle mass, which our muscle mass naturally decreases with age. So if you fight that and you participate in resistance training regularly and for the rest of your life, that will reduce your insulin resistance. Weight management reduces insulin resistance. Stress management with mindfulness or changing jobs if you need to, or, seeing a therapist reduces insulin resistance. And then sleep. If you sleep better, your insulin resistance will go down. So I know it's a little overly simplistic, but I like using that model of discussing inflammation because it enables patients to tackle it without getting overwhelmed.
So in terms of diet, are there any specific foods that would be good? The so-called superfoods, foods high in omega-3s.
So I don't buy into the superfood hypothesis. I think that it's one of those things that patients like because it's the easy answer, but I honestly feel there are no easy answers here. Michael Pollan, I have to give credit. I give out a list of his recommendations to a lot of my patients. Really, I think summarizes it best. He has a list of 3 basic things about food and a list of 7. I put the 7 in my after visit summaries for patients a lot, but the 3 basic are to eat real food, mostly plants, and not too much. That literally sums up everything you need to know about nutrition. Now, that's really complicated, actually, if you think about what's underneath those 3 statements. Eat real food. What is real food? Real food is food that will rot. Real food is food that your great-great-grandmother would recognize. Real food is food that you can pronounce every ingredient on a list of ingredients on a package. Real food is generally found on the outsides of the grocery store, not the packaged foods in the middle. Mostly plants. Okay, well, we're not talking about being a vegetarian. And in fact, I actually strongly recommend against vegan diets. But if you fill your plate with 50.1% vegetables and fruits, you're going to get a lot of nutrient dense and calorie poor foods, and that's going to be good for you.
Other prevention agents, I know in our supplements podcast, you mentioned turmeric, curcumin. Is that something to take proactively?
I would not recommend using it proactively. There's really no evidence that it would work as a prophylactic. I do recommend it to people who are actively struggling with joint pain, and we're trying to avoid putting them on NSAIDs, which are things like ibuprofen and Aleve. But I don't recommend anything as a prophylactic agent. I don't think there's any shortcuts.
Or getting it in food, in Indian food or spices.
Well, I love Indian food, so I absolutely recommend that. But, if you think about it, these traditional diets that are not the, meat and potatoes diets, they all have a couple of things in common. They utilize a multitude of different spices. That's good, because a lot of these spices seem to have natural anti-inflammatory properties. Makes the food taste really great. And a lot of these traditional and ethnic dishes have lots of colors to them, meaning they're getting, different phytochemicals, different phytonutrients, and they tend to have a lot of vegetables associated with them, minimizing, the caloric density that you're experiencing. And by the way, I'm not telling anybody that they should be a vegetarian if they don't want. And I think that protein intake is incredibly important, especially as you age. And the most efficient way to get protein is generally through animal proteins. So I don't want anybody to think that I'm saying don't eat any animal protein. I just think that it's important to balance.
Inflammation-targeted treatment. You mentioned the gout drug. Is there anything else?
So right now, colchicine just was approved for people who have already had heart disease at low dose to reduce cardiac events by about 25-30%. I don't know of any other, again, prophylactic or preventative agents that have been specifically approved for inflammation. Statins actually have what's called a pleiotropic effect, meaning that beyond the fact that they lower cholesterol, they also have some anti-inflammatory effects. So you could throw statins into that kind of list, even though they're not technically for inflammation. But I really do think for these chronic low-grade inflammatory related conditions, the key is lifestyle.
Lastly, you mentioned this before, but so you wouldn't consider this a unifying theory of disease?
No, I think that diseases in humans are too complicated. I had a professor in medical school named Steve Greenberg. He's an infectious diseases doctor who was the chief of medicine at Ben Taub in Houston, which is our county hospital. He's an infectious diseases doctor who said that all disease can be summed up in 3 categories and that they overlap. And those are trauma, genetics, and infection. So I have not found something that doesn't fit into those categories. And I would say that chronic inflammation is a trauma, right? Poor diet and, toxin exposure from bad air, poor lifestyle, that all is trauma. But there's still almost always a component of at least one other thing that's contributing, usually genetics when it comes to chronic disease. But you even see, for example, there's some cancers now that we know are triggered by infections like cervical cancer and head and neck cancer with human papillomavirus. So I think it would be overly simplistic to say it's a single unifying theory.
All right, very good. Well, I think that's all I have. Appreciate your taking time to talk with us. It was certainly an educational podcast for me.
Thanks for having me.
Okay.
Takeaways, guys.
My first takeaway is, Zach, that list of foods you read to avoid was a little depressing.
I feel like that's what I eat all the time.
Yeah.
I feel like that's my diet they just described.
It certainly was my diet in my 20s. So I hope you can reverse chronic inflammation to some extent, because I certainly had it in my 20s.
Well, that's the thing. Like when I'm being healthy, that's not my diet, but I have to actively be like, my default, what am I going to eat is that list. Like, I'm not even kidding. So that could explain some of my health ailments.
I think that's most people's lists.
Yeah.
I think from blog posts I've read that it's some percentage over 50% of Americans eats mostly processed food.
Yeah.
Yeah, I don't know. That was probably my biggest takeaway in the sense of really like staying accountable of how much of those foods I'm eating. I don't know, Todd, when you were talking to Dr. Septimus, what was your kind of like reaction to all of this?
I like you in my 20s, I ate a lot of that stuff, but at some point I cleaned up my act, and especially even reading your blog posts. Since I've been working here, I've continued to be educated about this stuff. I find that for me, eating at home, it's pretty easy to follow the advice. It's more when I'm out with people that I let my
social
guard down.
life is the biggest detriment to your health. I think
that really is the best
it's
point.
true.
But I felt like it was really encouraging that it sounded like he felt like you could really turn the ship around if you just get started with it.
Yeah, Dr. Septimus spoke about how some patients respond very well and can turn things around.
That was exciting for me to hear. And I was really surprised about how he spoke about mental health too, and how stress can cause inflammation.
Right. Stress is considered one of the big causes.
Stress.
Yeah. None of
We
us
all
have
have
any
it.
of that. I also got one of my questions answered, that I posed to you, Todd, in the sense of, okay, well, if we can't really know it's happening, what can you do about it? Sort of like, what's the story there? And I found it intriguing that he mentioned that blood work won't necessarily show low grade inflammation early on, right? So like right now, I know that I don't have high blood pressure, things like that, some of these things that are linked to chronic inflammation. But if I'm going to my doctor complaining about chronic fatigue, they can recommend just these lifestyle factors, because that is the preventive strategy of all of this. Like I liked that part, that it truly is not such a negative outlook, and that, this is the silent, like insidious thing that's going to like take us all down. There is still an exit strategy and like a forward path to avoiding it, or, like we all said, turning the ship once we get out of our 20s. I think a lot of us have done that. But for anybody who kind of hasn't taken that step yet, it's, you can do it.
No, that's super encouraging, because I'm one of the people who, like, if I want to do something at 3:00 and it's 3:05, I'm like, well, gotta wait till 4, So what if there's still a chance you can kind of still right the ship. I know we keep using the ship analogy, but riding the ship.
Yeah.
Look, we're using the
encouraging.
analogy. Let's go.
Yeah, no, that's encouraging. Turn that wheel. The steering wheel, right? That's what ships have.
Turn the
right?
tides in your favor.
What's the thing? Is it a steering wheel? We all know what I'm talking about.
Yeah. What is it called?
The stern? No.
Anyway,
I don't know.
Turn that thing 360. Turn that thing around.
180.
Yeah, 360 is not what you want to do in this situation, but yeah, 180. No, it's true though, because you get your mindset. Well, what's the point now, right? I mean, there's no way to undo the damage I've done, but there is, and that's encouraging.
And we heard so many of the most common medical conditions got tossed around in this episode: diabetes, heart disease. I think these are things that they're so common, and it's these early steps to take. And I know they're hard. Like, yeah, we all know they're hard, right? Like, I would love to just have a bag of hot fries for lunch today. Nothing would please me more. But, more times than not, it's making that decision to not have the bag of hot fries, have some, broccoli and a piece of chicken instead.
Don't make it sound so sad to be healthy, Kate.
I know. And I should say Mediterranean diet too. I think, broccoli and chicken, I think a lot of us, and maybe this is a whole podcast topic at some point, because I think the Mediterranean diet, I feel like it's come up in a couple seasons now, talking about like what that really looks like. I know we can rattle off lists of things, but I think a lot of people think it's like eating and being a vegetarian, and it's not. It's just getting rid of some of these processed foods and then eating plants. But, getting rid of the bad stuff is key.
No more 2 hot dogs at baseball games, as I've been known to do. So
yes.
I think for the next work gathering where they order in catered food, they should have seafood paella instead of.
I'm down.
I don't know
Fast
if I would eat catered paella. I'm going to be honest. How about something easier? Fish tacos.
Yeah.
Right there.
All right, well, that's going to do it for this episode of On Health with Houston Methodist. Share, like, and subscribe wherever you get your podcasts. We drop new episodes every Tuesday morning. So until then, stay tuned and stay healthy.